Thank you. Each year at the Ethical Society, we organize our programs around a theme. Our theme this year is Building an Ethical Future, and in March, we are exploring the future of health. To speak to that theme, it is now my pleasure to introduce our speaker, Dr. Jill B. Delston. Dr. Delston is Associate Teaching Professor at the University of Missouri, St. Louis. Her monograph is entitled Medical Sexism, Contraception Access, Reproductive Medicine, and Healthcare. Delston is the co-editor of a textbook entitled Applied Ethics, a Multicultural Approach. And I've enjoyed very much my time with her so far, and I'm looking forward to a really impressive talk in just a moment. Please welcome Dr. Delston to the podium.
Well, thank you so much for inviting me here today. It's such a pleasure and a privilege to be speaking to you here at this incredible institution. I was here not too long ago to hear Liz Winstead talk about abortion rights for an incredible event, and it's such a pleasure to see how much work this institution is doing to help Missourians and Americans. I'm going to be talking about some of the ideas in my book, Medical Sexism, and specifically I'm going to talk about, let's see, nope. Well, there we go. Specifically, I'm going to talk about contraception first and then move to abortion. No, it's not going to work. It's going the wrong way. No, we are going to have a fun time here. I don't need those slides. We can just have a conversation. I want to start with the phenomenon of access to birth control. It may seem odd to start a talk about abortion with a discussion of contraception, but it's connected to these broader issues of reproductive justice and autonomy. Doctors routinely deny patients access to hormonal birth control until those patients come in for unnecessary and potentially damaging cancer screenings. And I'm talking here about Pap tests. Pap tests are definitely a valuable part of preventative health, but they are recommended for most patients every 5 years and not every year, as they are often required. And they are never recommended as a means of behavior control, which is how it seems they seem to be operating. The high numbers of doctors who require Pap tests for prescription refills suggests that the practice is incredibly systemic in the field, and removing ongoing medical care in service of unrelated tests, unrelated to the safety or efficacy of birth control, is dangerous. It violates the scientific evidence, it meets the definition of medical malpractice, it harms patients, and it's in violation of their human rights. We also don't see similar policies in other areas of medicine. We don't see, for example, doctors withholding dialysis, say, until patients submit to a colonoscopy, even if a colonoscopy is incredibly necessary for their care. And so the gendered consequences of this unequal treatment point to medical sexism. Medical sexism is a definition that I offer in my book as just a gendered hierarchy in the medical field. And I use a definition from activist and writer Julia Serrano of traditional sexism and then adapt it to the medical context. And in this definition of a gendered hierarchy in the medical field, we can just see that intentions are not required to understand the implications of medical sexism. We don't need to know the beliefs or intents of doctors. They are not required for medical sexism to be present because systemic and institutional sexism is a major problem over and above any particular views of individuals within that system. And so the birth control, no, it's going the wrong way. I'm just going to let go of that. The birth control case study is valuable in its own right because birth control access is essential for bodily autonomy, but it also gives us a lens to evaluate other issues on the treatment of patients in healthcare more generally. And I argue that medical sexism is the main explanation for current and proposed abortion restrictions in the United States, just as it's the main explanation for birth control restrictions. The lack of adequate concern for women and people associated with women, more than any sort of moral commitment to fetuses, allows the proposed or actual policies. In fact, identifying medical sexism as having an explanatory role in contraception, where there is no fetus, helps make progress on cases like abortion, where there is a fetus. If abortion restrictions were really about protecting embryonic life or fetal life, then why do we see so many birth control restrictions, even though there is no embryonic or fetal life to consider? So there is no common thread of life to draw these cases and connect these cases and show the parallels, but there absolutely is a common thread of female autonomy to consider. Now, this is not a groundbreaking idea. If you belong to the ethical society, chances are you are pro-choice. And if you are pro-choice, chances are that you already believe that abortion restrictions are inherently sexist. After all, they sacrifice one's bodily autonomy to another's, and we don't allow this, again, in other areas of health. For example, thousands of people are currently on a waiting list for a kidney transplant, and all of them are undeniably full and autonomous persons, competent people with full moral personhood, right? But the government does not co-opt your organs to donate to these people, even if they will die without a transplant, and even if you do not need 2 kidneys to live. The relationship to the individual in need of an organ also does not explain this position. If you are a parent with an adult child who would die without a kidney transplant, and you are a match, no politician has yet argued that the government may forcibly take your organs for the use of another American citizen. Yet the Missouri government does do this in cases of abortion. And so famously, Judith Jarvis Thompson is a philosopher who made a version of this argument by imagining a famous violinist who is secretly attached with a machine to you, and you're the only one who can keep the violinist alive. So she asks, are you permitted to unplug yourself from this machine? And she argues that you are. So this organ transplant case, I think, is helpful in shedding light on the issue of abortion. And the contraception analogy is another helpful comparison that sheds light on this issue, because the case of contraception involves the same attitudes, the same behaviors, the same practices where no fetus exists. So when doctors deny contraception refills in service of Pap tests, they are but they are not ensuring that any sort of fetus's moral status or rights is protected, then we can see what's going on in the abortion case as well. So coming to a fuller understanding of birth control before progressing to a controversial and politicized case like abortion can bring more clarity, I think, on the role of the fetus in denials of care. And here's where I'll give you a trigger warning, because I'm going to move to talk about issues pertaining to rape. And the reason why is because I think that examining rape and incest exceptions to the legal framework in the United States is also a helpful and instructive way of understanding abortion restrictions more generally. So more than 60% of Americans say that abortion should be legal in most or all cases, and that number jumps to 70% when we include exceptions for rape. A standard understanding of the anti-abortion position as focused on the moral personhood of the fetus, however, cannot explain anti-abortion positions like this one. The positions that make exceptions for rape, for example, by definition, look beyond the moral status of the fetus. So I think what's going on there is a reduced moral concern about certain pregnant women, rather than a moral commitment to certain fetuses. And that is kind of what explains this phenomenon of rape exceptions. So special treatment in cases of rape and incest are allowed not because the moral personhood of the fetus shifts depending on the circumstances of conception, but instead because the status of the pregnant person shifts depending on the circumstances of conception. In the case of rape, the woman does not choose to have sex, and therefore her moral purity, her moral chastity are preserved in those cases from those perspectives. And so it's impermissible to override her bodily autonomy, even if an innocent bystander, the fetus, is sacrificed in protecting her rights. And so a victim of rape preserves her moral status by rejecting sexual intercourse and maintains her attendant rights as a result. So on this argument, the problem with abortion access is primarily that it allows for sex without the right sort of consequences. And so the standard anti-abortion position views pregnancy, labor, delivery, and sometimes motherhood as an appropriate punishment for a woman taking control of her own sexuality. The argument explains the connection between contraception and abortion, which seemingly are otherwise unrelated. The idea that a woman ought to be punished or face consequences for sex means that both contraception and abortion are problematic because they both divorce sex from the supposed consequences of motherhood and children. And so the anti-abortion position that allows for exceptions for rape and incest, which is to say the most popular anti-abortion position, aims to punish certain women and not to protect certain fetuses. And a concern for the moral status of the fetus cannot explain most anti-abortion positions. It cannot explain why anti-abortion positions, if they are about the moral status of the fetus, align so coincidentally with anti-contraception positions. And the problem with both contraception and abortion is, of course, not the moral personhood of the fetus, which does not exist in the first case and is not in question in the second case. The problem is this view that women ought to face consequences for sex. And I think as a result, the fact that expanding contraception access would actually lower the rates of abortions is not effective in arguing with this anti-abortion position. So we do not see, I don't think, anti-abortion positions and policies aimed at expanding contraception access. Now, I think some liberals point this out as an example of hypocrisy. Why would you not want to expand contraception access if you really care about the impermissibility of abortion? On my view, it's not hypocritical at all. It's the only consistent view to hold. So rhetorically, legally, politically, a more effective approach to the issue to discuss pro-choice issues would be to identify the sexism in these proposals. We call it out, we challenge it, and without mentioning sexism, an argument might be interesting or powerful, but it can't be complete. In other words, it attacks a smokescreen. The people who hold this position are holding it up, but it's not maybe their real view or their main impetus for holding that view. And it also shows why, oh yeah, we're way far ahead. I was gonna read the slide, but I'm not gonna do that. Yeah, let's do this slide. Thank you. It shows why there's a moving target. It shows why those positions change based on the sorts of attacks that pro-choice arguments offer. It also leaves unprotected pregnant people who are in a situation of labor and delivery. So in cases of labor and delivery, you've got a fetus which has the strongest of any, is the strongest moral personhood claims of any point during a pregnancy. And if moral personhood is sort of used as a cudgel against women in the labor and the delivery room, then it means that we don't have to listen to their choices. And that's precisely what we see happening with C-section rates, with episiotomy rates, with the maternal mortality rates in the United States. It appears as though they had bodily autonomy in the first trimester and it magically disappeared in the third trimester, but it was never there in the first place. It was this shifting idea of the moral status of the fetus. Okay, so in the next slide, in fact, when we bring medical sexism into view, other policies and trends start to make more sense. So views that withhold life-saving health care for babies and young children, while also endorsing anti-abortion positions, do not now appear contradictory or paradoxical at all, as is sometimes claimed by pro-choicers. But again, they appear now completely consistent. If they never cared about protecting the baby and they only ever cared about restricting women's rights and sexuality, then once the baby is born, helping the baby is less of an issue. It makes less sense. And if the difficulty in rearing children in this country underlines the danger in having sex and giving birth, then withholding help to those who need it can serve as just desserts for the undesirable behavior among those capable of pregnancy. So the difficulty that mothers face in the United States isn't the accidental byproduct of people falling through the cracks, it's the design. Anytime we ease the burden on mothers, whether it be through parental leave or paid parental leave or universal health care, universal preschool, anytime we ease the burden on mothers, we undermine the consequences for female sexuality. And so this discussion sheds light on a quote from the 1992 Supreme Court decision, which in light of medical sexism no longer even looks like a defense of abortion rights at all. So maybe we could proceed to the next slide. They write, the ability of women to participate equally in the economic and social life of the nation has been facilitated by their ability to control their reproductive lives in Planned Parenthood versus Casey. So now that statement no longer looks like a statement on the import of reproductive health or even a point of difference between the pro-choice and the pro-life positions. That the ability of women to participate equally in the economic and social life of the nation requires control of their reproductive lives is the one thing both sides can agree on. That brings us to the reproductive justice movement. Reproductive justice was coined in the 1990s by women of color to capture the ways in which the reproductive rights movement was incomplete. After all, choice cannot just mean the right to have a child if it doesn't also include the right not to have a child if it does not also include the rights to have children safely. And the end of prohibitions against contraception and abortion did not necessarily mean that everyone could equally access them. Once we bring reproductive justice into view, we can see how differential access is a problem even when abortion is legal. So Kimberly Crenshaw, who coined the term intersectionality, writes, quote, the decision to overturn Roe versus Wade will be lethal to Americans, particularly Black and queer people, who will now lose their already limited access to abortions. And that brings us back to the access issues that I opened this talk with on contraception. One issue with access to restrictions on abortion is that they are coming not just from politicians and employers and courts, but also from within the medical field. By working at hospitals who deny patients needed medical care, doctors make those hospitals viable. Doctors also choose to work for institutions which restrict their patients' access to needed medical care. So that's a major obstacle for patients, even where abortion is legal. You take a perfectly safe medical procedure, one that was legal for 70 years and still is in many places, a procedure all OBGYNs are trained to perform, and you get most physicians refusing to do it. And that's before Dobbs. So going on to the next slide or two, one more. 75% of OBGYNs reported having a patient who wanted an abortion in the last year, and less than a quarter of them were willing to provide an abortion to their patients. 35% would not even provide a referral to somebody who would provide an abortion. So this is pre-Dobbs. You know, what's going on here? I think for rural areas, we found that the distance exceeded 180 miles on average for an abortion provider. The average distance nationwide was 14 miles or 20 minutes, and that's by comparison to people who had access to health care more generally that was just a couple of minutes away. Why? Why is this most basic form of health care such a large obstacle to so many when most people live just mere minutes from health care distributors? The fact that the nearest hospital is orders of magnitude closer to patients than the average abortion provider means that a large number of these hospitals are simply not performing this operation, despite the fact that abortions are needed medical care for many. And so people without a uterus, they can get their needs met, their medical needs met close by. But people with a uterus are not so lucky before or after Dobbs. Now, after Dobbs, This is a map that shows the after Dobbs situation. The situation is obviously much worse. Today, 58% of women ages 13 to 44 live in a state with abortion restrictions and would have to go out of state to get one. As you can see, most of them cannot even go to a neighboring state. But we can't pretend that the places where abortion is legal include opportunities for people to receive abortions because of the pre-Dobbs landscape. And it's not as though abortion is specialty care. Abortion training has been standard in OB/GYN curricula since the 90s. If discipline guidelines are any indication, you do not even need an OB/GYN or to be an OB/GYN or to receive that training to be able to perform the procedure. ACOG, among other organizations, advocates for family practitioners to be trained and offer abortions. And hospitals anachronistically tending towards private status are also not enough to explain this feature because private hospitals offer a range of needed services to all. Now, I want to bring up the issue of religion because I think it's another smokescreen here. 1 in 6 hospital beds in the United States are in a Catholic hospital. In 10 states, more than a third are. The closest hospital to you and where you live might be a Catholic hospital here in Missouri. And at these institutions, doctors are not permitted to perform abortions, even if state law allows it. And so for that reason, doctors are both the perpetrators and the victims in this system. They're the perpetrators because they're agreeing to work in these institutions. Imagine there were policies that said you're not allowed to, vaccinate newly born babies for measles. Doctors would refuse to work in these institutions. They would say, if I can't provide a full medical care to my patients, then I can't agree to work in these institutions. But that's not what happens when hospitals want to restrict their rights to provide abortions. It looks like they are the perpetrators of the system, in part because they're agreeing to live in a world where to make viable these hospitals. They're also victims of the system because their rights are being violated. They are victims because they often work for institutions that violate their religious freedom. Before Dobbs, the laws and policies protecting institutions who denied those previously constitutionally protected abortion rights often protected the religious freedom of a corporation or institution over the religious freedom of the individuals who work at that institution. So when an individual's religious rights are in conflict with a corporation's, the law chose in many states the corporation. And those policies give a lie to what's going on. It can't possibly be about religious freedom at all. If it were, then the religious rights of doctors to follow a religion that differs from their employers would be protected. So for example, in a state like Delaware, and in many states, I could read that quote, but in many states, the laws have on the books all of the things you can't be sued for if you deny somebody an abortion, that your imminent death, any sort of harm and pain and suffering that arise. They have to write those into the books because otherwise hospitals and doctors would be not just criminally liable, but also civilly liable for that sort of those tort claims. And so they have to write in, sometimes with shocking specificity, all the potential harms that could arise from not being able to receive an abortion and how there's no recourse for the patient in those cases. And so it's not that hard to think about atheists and agnostics and certain religions like Judaism that not only think that abortion is permissible according to these strongly held beliefs, but sometimes also think that it's obligatory. So I don't need to tell you secular humanists about the ways in which our strongly held beliefs might differ from a Catholic's. If one's religion or conscience stipulates that abortion or contraception is permissible or required in certain cases, then denial of one's wishes would amount to a religious discrimination. In other words, if it's religious discrimination to force a religious doctor to provide an abortion, then it might similarly be religious discrimination to force a religious doctor to cause the death or injury of another through medical negligence. So currently, doctors who deny abortions are protected by state laws, And if a doctor's religious or moral conscience prohibits them from imposing these preventable harms on patients, we could protect them from employer retaliation, but we do not. The fact that doctors are often not protected or only protected if they are Christians demonstrates that religious freedom was never at stake. Medical sexism and not religious freedom drives the legal landscape. So I want to conclude by summing up that medical sexism exists. Medical sexism is deadly, but naming the problem can also help us solve the problem. It can help us root out discriminatory practices, it can help us change the narrative, and it can help us pursue reproductive justice and do better. Thank you.
Right? Wonderful. So fantastic. Thank you so much for sharing today. The ushers will now take up a collection to support the society. If you are moved to make a donation today, we appreciate anything you may be able to offer. We rely on the generosity of our members and our friends to ensure our community can keep providing our many free programs. And if you don't have cash with you today, that's okay. You can donate at ethicalstl.org/donate or use the QR code. Or even better, you can become a pledging member. If you are interested in joining the Ethical Society, our membership coordinator, Laura, will be available afterwards to answer your questions. And we would love to keep you informed about future events at the Ethical Society of St. Louis. If you would like to join our weekly newsletter, you can use the other QR code above me to sign up. You can also sign up on the website. And then I have a number of announcements to share with you today.